Hi, everyone. Welcome to this week's lecture on anxiety disorders and obsessive-compulsive disorders. I know it's a lot to put in 1 week's worth of reading. I'm including all of this together, and I'm really starting off with all of this because I believe that this, just like what we started off with in talking about depressive disorders, anxiety disorders really are the foundation for us understanding how anxiety shows up not only in this particular set of diagnoses, how it shows up in obsessive compulsive disorders, but how it, unfortunately, I guess, paves the way for a lot of the other diagnoses that we're going to talk about. Trauma disorders, personality disorders, even something like ADHD, where anxiety lives can be very central and close to other disorders that we're going to discuss. And so this is a foundation for understanding what anxiety is, what that looks like, and what it is not, because it obviously is a very commonly used word. And so we're going to break this down during this particular lecture. So here are all of the disorders that we're going to review in this particular lecture. We are going to pay special attention to generalized anxiety disorder, obsessive compulsive disorder, panic disorder versus panic attacks, agoraphobia, social anxiety disorder, separation anxiety disorder, and specific phobia. And I'm going to do my best to really break those down as much as possible. I mean, the disorders themselves, as far as the criteria, are actually pretty short, but I will do my best to explain them, to conceptualize them. We are just really going to do more of a one-sentence review for selective mutism, hoarding disorder, excoriation disorder, which is skin picking, and trichotillomania. So overviews when needed and deeper dives when not. All these animations. Okay. So overview of the disorders starts with the conceptualization of these disorders. And so ultimately, what's important, I've really compiled in the development of this particular lecture is understanding the difference between anxiety, fear, avoidance, cognitions, and I guess not so much the difference, but understanding how these are foundational and how we continue to see them, these words and these ideas pop up within anxiety disorders, in particular within anxiety disorders. So starting with the word anxiety, because as I said, this is something that can be overly used without a lot of clarity about what it is or what it isn't. So anxiety is the anticipation of a future threat, and that is experienced through worry, apprehension, dread, for instance. And it can look like stress. Stress can be nebulous as far as what that actually looks like, sounds like, feels like, etc. But so anxiety essentially is the worry that something bad is going to happen. And so that sounds like this notion of something bad is going to happen. What if? How can I handle this? The worst case scenario is probably going to be this, but it's ultimately along these lines of fearing that something bad is going to happen. And this can be, and I know the definition of this says anticipation of future threat. I know that we can actually experience anxiety thinking about things that have already happened, thinking about things or experiencing something that is currently happening, or dreading a future situation. But that's really what it's calling for, is regardless of what has happened, regardless of what is happening, that there's this fear that something bad is going to happen. I'm not going to be able to know how to handle it. And that experience overall is very overwhelming and distressing. Fear is a little bit different. Fear, this really goes back to an evolutionary standpoint, which is like we're supposed to be afraid of particular things, right? We're supposed to fear particular things for the sake of our survival. But when it comes to a disorder, this is where it's above and beyond something that's actually real danger. And it translates to an emotional response to real, we're including this in here, but it's a or perceived imminent threat. And so this activates our fight or flight response mechanism. This puts us into run, hide, fight, flee, puke type of reaction that really is a deeper level than something bad's going to happen. It's more like, I'm going to die. There's danger and I'm going to die, or there's danger and somebody else is going to die. That may not actually be thought when somebody is experiencing a particular type of fear, but at a deep core level, that's really it. It's different from something bad's going to happen and I'm not going to handle it. Fear is like, oh my gosh, this is a life-threatening situation. And what we'll learn about is the difference between actually a feared object that does carry a life-threatening, I was going to say opportunity, but that is actually life-threatening versus um, versus a perception of a life-threatening situation. And this is really what our anxiety tells us, is that we have to be afraid of everything, because our fight or flight response is so overly activated when it comes to fears that are dysfunctional, fears that really are diagnostic. But that's the difference between anxiety and fear. I think we know this, but this is breaking it down from a clinical perspective as it relates to the DSM. And avoidance is behavior that's designed essentially to reduce exposure to whatever perceived threat, obstacle, overwhelming experience somebody is dreading, somebody is believes that they are facing, etc. And so the consequence to avoidance, while this seems to serve as a protective mechanism in the moment, while this becomes really part of a vicious cycle of avoiding something and not being able to handle this, and essentially disconnecting from an opportunity to endure discomfort for the sake of walking through what is fear, what provokes fear, walking through what provokes anxiety. The ultimate consequence is that it continuates to perpetuate our anxiety or fear. If we keep avoiding something because we don't know how to face it, because we perceive that it's actually an imminent threat to us, then that suspends our anxiety, it suspends our fear. And the more we avoid something, the worse that fear, the worse that anxiety gets. And so, what this sounds like is, if I avoid this, the risk will decrease, or I won't have to deal with it, right? If I avoid this, then I'll be safe and I won't come into any sort of harm or danger. And then lastly, cognitions. These are the associated thoughts and beliefs that either precede or perpetuate the disorder. These are really the thoughts, whether they are recognized in one's particular psyche, or when thoughts are almost kind of like a feeling that you just know, like you're just kind of locked into whatever experience you're having, even though you may not have words that are narrated in your mind. That's what we could identify as a cognition. So these are essentially thoughts, beliefs that are a significant component to perpetuate the disorder. And so I would say, in continuously looking at these disorders and really focusing on the structure of these disorders, that there's all of these disorders have some sort of central or associated cognition. Usually the central or associated cognition is in the form of an I statement. I'm not safe. I can't handle this. What if this happens, etc. But phobias are less about that. They're more about danger that's actually posed by the particular object or situation. So like, that's dangerous is less about I can't handle this. It's more like that's dangerous and I'm going to die. Ultimately, it sounds like I cannot handle what's going to happen. From an overarching perspective, a lot of these disorders is I'm not going to be able to handle what's going to happen. Something is provoking my apprehension. Something seems like a real threat, and I'm not going to be able to handle this. And I'll tell you that in doing this work and working with anxiety disorders, sorry, my dog was freaking out. But in supporting your clients or patients with their anxiety disorders, with obsessive compulsive disorders, if you really get down to that question of, hey, what are you worried about as it relates to your ability to handle this? That's the central theme that you'll encounter, is I'm not good enough. I'm not capable enough. I can't manage this. What if I mess up? There's some sort of element about it being seemingly out of the person's control, that they won't be able to handle it. And as a result, something, again, bad is going to happen. If you can do that, I think it makes treatment of anxiety disorders so much clearer and more palpable to the person, and it just makes the conceptualization easy for you. So that's why I break it down right now. Okay, and this is borrowing from from CBT's cognitive triad for anxiety disorders, but translating, so the cognitive triad states that our thoughts are connected to our feelings, which are connected to our behaviors. And so when we have maladaptive, irrational thoughts, that essentially impacts our feelings and our behaviors to the point of causing distress and impairment. If I'm worried, if I'm overwhelmed, if I am essentially fearful of something that's going to happen, it's not going to be likely that I'm going to be happy-go-lucky and at ease, right? It's going to change my feelings in that particular situation when I'm encountered with whatever distressing thought I'm experiencing. And then that's going to change my behaviors too, right? More from a general standpoint, we have a lot of different types of behaviors that emerge when we are overwhelmed, when we are anxious, when we're worried, when we're experiencing dread, when we're dealing with a feared type of situation. But what this comes down to, as far as these particular disorders and the shared conceptualization, is that interplay between cognitions, fears, and avoidance. Okay. Fears and anxieties and avoidance. So, and I think sometimes it's the idea that if I am not necessarily sure what's happening, but I can pull out, like, or I can really speak to, if I can address one behavior or one part of the triad, then I can fill in the gaps of the rest. So sometimes you'll have people that are just very clear about exactly what they're thinking or exactly what they're feeling and how that affects them. And sometimes you'll experience people that just like are very shut down and are like, I don't know, I freeze. Okay, well, what triggered that? I don't know. I just like something happened and then I just like my mind goes blank. And then we can connect that to avoidance. And so ultimately, I've found that this is a really helpful tool, not only for your conceptualization, but just for educating your clients and your patients, and then really being able to build treatment around that. But focusing on how does this process particularly look with somebody in their life, and then being able to treat it from that particular angle. Okay, so one more component of building these disorders and their conceptualization, more conceptualization and understanding of how anxiety disorders and OCD disorders show up. A lot of these disorders actually don't have, I don't think all of these disorders, pardon me, do not have an age of onset. There's no requirement in the DSM criteria as far as age of onset. So we do know that a lot of these disorders, and you can see this in, oh, you know what? I need to actually, here we go. You can see this in the tables in the back. I really break down a lot of the disorders and give you information, like an overview of the disorders, so you can continue to process it. But a lot of what the DSM talks about is that the emergence of these disorders can show up in childhood, in adolescence, early adulthood. And so anxiety disorders in particular just can really wreak havoc on a person's life, depending on the treatment that they receive, depending on the treatment that they, just the support of the environment, and what that looks like for a person as far as their resources, their resilience, etc. So we do know that, generally speaking, the earlier the age of onset, the greater the possibility of comorbidity of either other anxiety disorders or other DSM disorders. And so symptoms can essentially become increasingly more severe over time, especially when untreated. And so I'm going to show you this pathway, which is not a prescriptive pathway, but just speaks to what the course of these disorders can look like. So we have to take in a lot of different things into consideration. We have to take in, again, genetics, heritability. We have to take in just like what the environment looks like. So if I am a child or a young adult and I have generalized anxiety disorder and I live with a lot of other people that have generalized anxiety disorder, and there's a hyper focus on behavior, on performance, there's not a lot of distress tolerance, it's very possible that I'm going to continue to experience my generalized anxiety disorder. And depending on what I go through, how that anxiety affects me, I might develop something else as well. So this is not like threatening anybody with a bad time. It's just recognizing that these can very much be insidious and continue to follow a person throughout the development of their life. On the other hand, I think for like separation anxiety disorder, it talks about that there are really favorable outcomes for children that develop this, that essentially it can be something that they grow out of and can experience stability over time. It just really depends. We do see that anxiety disorders in particular favor wreaking havoc on females over males. So we see a 2-to-1 ratio as far as the expression of anxiety disorders and obsessive compulsive disorders, actually, in girls and boys. I know, I don't know, I just think that it's really kind of evolutionary too, that for women in terms of like longer standing gender roles, there's a different kind of awareness that they have to have or had to have as far as survival, as far as taking care of roles and responsibilities and making sure that everybody literally is alive. And so I think that there's a broader situational awareness that has been developed in women and a different kind of emotional attunement. Guys, it does not mean that you are not situationally aware, that you're not emotionally intelligent. I just think, and I hope I'm not overly generalizing, but I just think that as far as like women who are mothers, there's just a heightened level of awareness about everything that's going on and need to compute things. And so I do wonder if that's where we see more of an expression. I don't know if it's a chicken or the egg. I'm not sure. Either way, we see this more prevalently in women than we do in men. Thirdly, one anxiety disorder can be comorbid with another anxiety or OCD disorder. This really kind of speaks to number one. But we also can see that there's a high comorbidity with other disorders outside of these chapters. We can see a high comorbidity with major depressive disorder, bipolar disorder. There's actually a really strong comorbidity of I think it's generalized anxiety disorder and bipolar disorder. And we definitely see a high comorbidity of anxiety disorders, OCD disorders, and substance use disorders. But they have to be severe enough to essentially warrant clinical attention rather than irritability that we might associate with major depressive disorder, bipolar disorder, sleep issues, avoidance issues, fatigue. I meant it the other way around. We cannot say, sorry, what I'm trying to say is when we have pre-existing disorders such as major depressive disorder, bipolar, substance use disorders, and then we see traits from anxiety disorders, from OCD, so irritability issues, sleep, avoidance, fatigue that comes from worrying, and generalized anxiety disorder. If these factors alone actually don't fit into any of the diagnoses for anxiety disorders or OCD, then we wouldn't actually diagnose this. We have to see that comorbidities really do meet the full criteria. Maybe this feels like extra, or you're like, yeah, I get it. Like, of course, they have to meet criteria if we're talking about them being comorbid disorders. There's just a lot of overlap, and irritability can be very vague. It can be very broad. Sleep issues may come from these disorders, may not. Avoidance, again, we talk about that being the clinical conceptualization. It's a matter of what it's attached to, what cluster symptoms are occurring in a person's presentation, and is that enough to actually fit within a diagnosis? So that's why I spell this out. But talking about comorbidities and overlap, looking at points 1 and 3, I have a client in my private practice right now who had severe separation anxiety disorder, like pretty severe. And then that turned into social anxiety disorder. And like at one point, she said when she was in high school, she like could not walk around campus without somebody right there. She had to have friends like walk her to class. She really could not be by herself in social situations. She's not like that anymore, but she has an alcohol use disorder, and alcohol use emerged from college era times where this was still happening. And so I just think that for her, it's not interesting. For her, it's really debilitating. But I just think that it's important to identify how these disorders essentially create more susceptibility for coping and maladaptive coping, and whether that actually fits into a disorder or whether that speaks to development of another disorder. I don't know. They just go hand in hand. Okay. Lastly, on the slide, this is what I really want you to take away from the disorders and the criteria in general is we're going to see repetition in anxiety disorders that I call it PAP, PAPP, provoke, avoid, proportion, and persistence. In a lot of our anxiety disorders, we are going to see that repeated in the criteria sets over and over and over again. And so I'm going to break this down. But exposure to the feared stimuli almost always provokes immediate fear or anxiety. It's really like a foundational understanding of whatever a person is fearful of, whatever a person is anxious about, it really comes down to fear, is that any sort of idea or possibility of being exposed to this bad thing or this very dangerous thing is going to provoke immediate fear or anxiety, immediate overwhelm, immediate fight or flight response. And as a result of that, the situations are either avoided or endured with intense fear and anxiety. Avoided if they have a choice, but if they do not have a choice, endured with intense fear and anxiety. And I'm going to talk about this in the next slide as an example that came to mind when I was creating this. The fear or anxiety is out of proportion to the actual threat posed by the specific object or situation. I have this actually in my other slide that I forgot to mention, where what we fear, we perceive is actually going to cause us danger. If you're listening to this over the podcast, what I have on this particular slide is a little girl who is looking at a cute kitten, and she has a thought bubble, and in the thought bubble is a roaring tiger. And so where we misperceive, or is that a word? We misinterpret, that's the word I'm looking for, misinterpret one object and essentially determine its level of danger within that fear. And so something like a cute, cuddly kitten, I know this typically doesn't happen as far as a phobia. People love kittens. But something very minor to anybody else might seem so significantly dangerous, fear-provoking, overwhelming to the person that has that particular anxiety disorder. And so they avoid it at all costs. If they have to experience it, it causes a great deal of distress and overwhelm because that fear or anxiety is out of proportion to the actual threat that's posed by the specific object or situation. So a kitten is probably not going to kill you. A tiger very well could, right? So we lean into tiger and can't ascertain the difference between kitten and tiger from that anxious, overridden state. That amygdala is going crazy. And it's like, get out, get out, get out, get out, get out, danger, 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 danger. Okay. And lastly, the fear and anxiety and or avoidance within these disorders is persistent. This typically lasts 6 months or longer. For some people, it can last for years and years and years, even though they may not be exposed to particular stimuli that will cause that particular fear, anxiety, overwhelm, but it's still there. So, unlike a lot of the disorders that we've already covered between weeks 4 and 7, anxiety, OCD disorders, unfortunately, these are not episodic. It's pretty continuous. And depending on the disorder that we're going to talk about, this is something that might be endured every single day or nearly every single day, or something that, again, when a person is put in a situation where that is being presented to them, is going to cause a great amount of distress. Okay, so let's go back to PAP, provoke, avoid, proportion, persistence. Lots of avoid, per, okay? Pro, avo, per. There you go. Now, when I think about this, I think about the movie. I'm quoting this. I'm referring to this movie, the movie Jackass 3, and one of the main people in the Jackass family is Bam Margera. Oh gosh, I could talk a lot about him, but I won't. Bam in real life has apparently a very significant fear of snakes, like terrified of snakes. So we would say that he probably has a specific phobia of snakes. And so his loving, supportive, wonderful friends, what they do in this scene of the movie is they prank him and they essentially lure him into a trailer where he thinks he's going to do a completely separate prank. The trailer has a false bottom, so he walks through this essentially turf looking he walked onto this turf looking floor, and then it has a pit. When he falls into the pit, there are a bunch of rubber snakes at the bottom. And if you watch this video, I'm not going to play it because the language is like, I can't endorse the use of the language from my professional standpoint. I linked it in the lecture. You can watch it if you want. It's really excruciating. I mean, I don't know how long ago this movie came out, but it's really excruciating from a clinical standpoint because you see him fall into this. He thinks that that's the prank. He thinks that once he's fallen through the floor, that like that's the actual joke. But then he looks and sees a bunch of these rubber snakes, and you see him go from laughter to complete terror. And then again, his wonderful, just like deeply compassionate, empathic friends, what they do is they throw live snakes into this pit. I think for a lot of us, actually, I really like snakes. I don't know why I missed that fear. I hate spiders, but for a lot of people, they would be completely terrified, right? For him, you see just he is like dying to get out of this pit and they keep throwing these snakes in there. The reality is I don't think any of the snakes are actually poisonous. Like none of them are actually going to harm him, but he is trying to get out of this situation to the point of pleading with his friends, please guys, please, this isn't funny. Please get me out. Not a joke. You see just the amount of terror and distress that he's in. So this is him really even thinking about a snake is going to provoke fear or anxiety. My guess is he avoids anything that has to do with that, right? And being in the situation where he actually can't avoid it is prompting a significant amount of distress, a significant amount of intense fear and anxiety, because his anxiety is directly out of proportion to the actual threat posed in this particular situation. And this is probably followed him over the course of his life. I don't know if he's ever, Bam needs a lot of treatment. This is probably not the priority. In real life right now, I think most of his friends are actually sober and he like refuses to get sober. We can talk. Oh, we already missed it. Another conversation for another time. But point being, if you want to see terror, not to be sadistic or anything, from a clinical standpoint, this is what this can look like. Okay, if you are listening to this, I will do my best to describe this particular slide, but here is what I'm identifying as far as conceptualization pathways and how I've, in looking in the different disorders of the DSM with comorbidities, with just, the course of these disorders, where these can lead to. To describe what is happening on the slide, I have essentially 3 different columns in one part of the slide and one column with a bunch of arrows leading to another disorder in the second part of the slide. So we have like our gateway anxiety disorders, separation anxiety disorder, and selective mutism. Now, again, it's not like a prescriptive magic formula, but they can be highly comorbid with one another, especially untreated, and can lead to the development of other disorders. So separation anxiety disorder can lead to a specific phobia. It can lead to generalized anxiety disorder. Specific phobia can then lead to panic disorder or panic attacks. And generalized anxiety disorder can lead to panic disorder, can lead to panic attacks. It can actually lead to social anxiety disorder. I don't know why I would put that, even though that's really more anecdotal than it is in what we see in the DSM. And once we're in the realm of panic disorder, this is where our bodies are much more primed to respond to potential threats of fear, to anxieties at a point that can be really debilitating. And at worst, Panic disorder can lead to agoraphobia. We'll talk about this when we get to agoraphobia as far as the disorder itself. We also can see that social anxiety disorder and specific phobias can lead to agoraphobia. So as far as the anxiety disorders players are concerned, as far as the roster is concerned, agoraphobia really is the most distressful and debilitating, because what it entails is that somebody is really not leaving their home. That's what I would think is like the highest degree of distress and impairment. We've talked about this already. If you're not getting out of your house, and because everything seems so scary and you don't know how you're going to handle a potential panic attack, that's really like the worst type of anxiety there is, right? You're boxed into your life. Moreover, specific phobia, generalized anxiety disorder, social anxiety disorder, panic disorder can lead to the development of obsessive compulsive disorder, or can be highly comorbid with compulsive disorder, with OCD. I think that there's just a lot to be said about the persistence of these disorders, and how we'll see this when we get to OCD, how the persistence of these disorders keeps people in a heightened state of arousal and can essentially lead to compulsive behaviors that are designed to manage the anxiety of a feared situation. Some more on that to come. Going into the anxiety disorders, starting with separation anxiety disorder, ultimately we see separation anxiety disorder in children, adolescents. Although the DSM is written for this to be demonstrated in adults, but ultimately what this centers around is a fear of something bad happening to key attachment figures. And as a result of this particular fear, the child, the adolescent, the adult does not want to leave the attachment figure. If they have to leave the attachment figure, that is going to generate a lot of distress and overwhelm. I know I'm repeating some of these words, by the way. It's just, they're the most appropriate words in my word bank. But so this fear of something terrible happening causes a significant type of reaction, which essentially creates ongoing avoidance and refusal to separate from the key attachment figure. And so we see that in looking at the criteria, recurrent excessive distress when anticipating or experiencing separation, there's persistent excessive worry about losing attachment figures and some sort of harm befalling them, injury, illness, disaster, death, like natural disasters. That's really kind of like a common thing, that something bad is going to happen. There's going to be a storm. There's going to be an earthquake. We live in Southern California. There's going to be an earthquake. There's going to be some sort of accident that happens that will cause separation and essentially, not being able to return to major attachment figures. And as a result of that, this is where I'm just going to say kids, because we see this in the majority of the population. We see this in as children. Refusal, reluctance to go out, to go to school, to go to a friend's house, not wanting to go spend the night at other friend's house, not wanting to do sleepaway camp, really not being able to do things alone without, or just even like it for a short period of time, separating from their attachment figures. And we can also see nightmares that are perpetuate that fear, where like really terrible things happen to their not significant others, their attachment figures. I think kids even will claim that they don't want to be alone in their beds by themselves, because this is where they see some sort of monster, or somebody's peeking through the window and looking at them. I mean, really legitimately scary stuff for a kid, right? And then ultimately, at the possibility or actual separation of attachment figures, we might see somatic complaints. I remember when I was working in not this East County, I was working in San Bernardino County, and was doing parent support and child support classes, early intervention classes for parents and their children. We had one class that we had started, and it was like one of the first of 8 weeks of an 8-week course. And so we had a lot of new kids come into this particular particular room. This is when I had just graduated from undergrad. And so we would work with these kids. And I remember this one kid came in, parents dropped him off. He brought him with his brother. Brother was fine. But this, I think he was like 5. He was inconsolable, like just so distressed, was like crying, pounding on the door, wanting to see his parents. I brought him on my lap. I was like trying to comfort him and console him, and he threw up all over me, like just like "Ah, ah," all over me. Just in complete distress, complete and utter terror at being separated from his parents. So, needless to say, I had to go get mom and be like, I'm sorry, your son is not doing well. You need to come get him. And I don't think that they came back. I think this kid was just like quite debilitated by this possibility of being separated by his parents. And I think it's notable that I say he was 5 because what we do see is that, in kids around a year, this is actually demonstrative of secure attachment, right? We want kids to have stranger danger. We want infants, toddlers to have stranger danger. We want them to get distressed because that is really signaling the existence of secure attachment. It's just when kids learn that they can trust other people, when they learn that there are other figures in their lives that may not be secure attachment figures, but are other safe people, and they can differentiate that, that's where we see distress start to change. But for this disorder, that doesn't change. That continues to perpetuate and provoke a significant amount of anxiety and overwhelm about the possibility of harm befalling their secure attachment figure. And so ultimately, we have to see persistence in children. This lasts 4 weeks or longer, and adolescents, in children and adolescents, pardon me, and then 6 months or more in adults. So that's going to be a repeat number for adults. This causes significantly clinically significant distress in one or more areas of functioning. I know it doesn't say one or more. It's in social, academic, occupational, or other important areas of functioning. So I think you're going to at least see one or more outside of the home environment. Okay, so let's see. That's really, and this is where you just need to look at the comorbidities of we're not seeing this happening because of any psychosis. We're not seeing this because of agoraphobia. This is not happening as a result of generalized anxiety disorder, that it's one part of other worries that a person's having. I would say just like even an illness anxiety disorder, just, something that's more contextually valid. Okay, selective mutism. This is what, again, we see in children, what we can see in adolescents, but this is failure to speak in social situations where there's an expectation for speaking. Failure to speak at school, failure to speak with friends, despite being able to converse more freely at home in the home environment, again, a safe environment. This is going to persist for at least a month, not just limited to the first month of school. Like, kids can be understandably shy, and this is really not attributable to shyness. And it's not better explained by a neurodevelopmental issue like autism spectrum disorder, any sort of communication disorder, psychotic disorder. This is really a type of anxiety disorder that causes the child to really abstain from speaking, answering questions with adults, with other kids, and can be persistent in that sense. And that it's not also due, I'm kind of going around the different criteria sections. And this failure to speak is not because of a lack of knowledge of the language. It's not because English is a second language, or whatever language is spoken that needs to be spoken is a second language. This is really this particular fear of engaging with others and not speaking as a result of this. I actually had a client when I worked for the county who, I didn't realize this until like later, but was like pretty much, I would have said, had a working diagnosis of selective mutism. Oh my goodness. And she just would nod, would shake her head, would point to things. She had to have her caregiver or grandparent, I think, yeah, it was her grandpa, come in, and he did a lot of talking for her. She was 13, 14. She had like just, it was very challenging. And then the time that she stopped, I mean, that she started talking is when she, like, I said something and I was wrong about something geographical. Yeah, I think it was, we were talking about geography. I was wrong. And she started laughing at me and I totally took it personally and was like, well, this is so embarrassing. The first thing that she does that actually is like, engaging with me, she's making fun of me. But I think that she was like, just couldn't actually correct me and had this very incongruent type of affective response and just kept laughing. It was so weird. It was just so interesting too. But with my 25-year-old ego strength, I was like, what did I do? Anyways, so that's selective mutism. Specific phobia, this is what we're talking about with BAM and the snakes. So ultimately, it's a marked fear or anxiety about a specific situation. So we can see snakes as a particular object. We often see this as far as flying, heights, animals, blood, receiving an injection, but it's a particular type of theme and content. We don't necessarily see it shift from a specific phobia about flying and then to heights and then to animals and then to blood. It's really like that particular object or situation is what triggers the overwhelm for the individual. We can see this in children. Again, we can see this in adults or adolescents or adults. We don't have any, there's not Yeah, there is not actually a demarcation as far as children and adults versus, oh my goodness, why am I saying this? Children and adolescents versus adults. So ultimately, the fear, anxiety, avoidance that we see is going to last for 6 months or more. But um, here is where we start to see PAP, right? The marked fear or anxiety about a specific object or situation. B, the phobic object or situation is almost always provokes immediate fear or anxiety. The phobic object is actively avoided or endured with intense fear or anxiety. That fear, anxiety is directly out of proportion to the actual danger that's posed by the particular situation. And this is persistent, again, lasting 6 months or more. So there we have a lot of rule outs. We have to look at what's the context for this. How did this emerge? Is there a better way to be able to explain why this is happening? Does this really speak to a bigger diagnosis of agoraphobia, of OCD, of PTSD, separation anxiety disorder? It's like, as a child so distressed of cars, we think that it's a specific phobia of cars, but it's because they don't want to be driven away from their caregivers. I don't know. So that's the gist of it. I really explained it in talking about Bam and his situation. But so you just need to code based on the particular stimulus. So if it's an animal, a natural environment, blood injection injury, so any sort of like needles, invasive procedures, like, just not wanting to see any sort of blood or like just I don't want to have anything to do with that needle. Don't show me. I know I don't even want to do shots because not take shots, but receive a shot because I don't want to have anything to do with that needle. Something bad's going to happen. This can be really dangerous. And this is where we can see people actually avoiding like doctors' offices. That's the avoidance component, that they don't want to be in any type of medical service or receive any type of medical service because the idea of being exposed to that is so real and so possible. And so people will avoid receiving medical care if they have something like a blood injection injury type specifier, for example. Let's see. Yeah, I think that's it. I guess there's a lot of different coding notes that you can utilize depending on the particular situation. But I would say that like this can really be, I mean, claustrophobia, right? Like it's a very common thing. I don't actually know what the phobia is for heights. It's acrophobia, acrophobia. So yeah, that specific phobia. Acrophobia, not to be confused with arachnophobia, right? Oh my gosh. And
Would you like me to open the
which,
door for you?
Okay, so here's a video I found on TikTok of this mom who they live in Australia, and oh, can I do this? No. They live in Australia. There's a giant huntsman spider in their car, and this poor woman is really struggling. I gotta get this out of the way. Really struggling because she's got to take her kids to school.
Would you like me to open the door for you?
No.
What about you go behind it and then open the door and then go around? You're gonna have to, Mum. Do you want to go to school? Us to go to school or not? Or do you just want us to stay home? Oh, it's huge. Crap.
Oh my god. Science. Woo! Where is it?
I can see it. It went under the tire.
I hope you can hear this.
I don't think so. Go around the other side.
The mom is terrified, right? She has to do it. She's talking herself
can't
up
see
to
it
try to
anymore,
open
Mum,
this
but
door
I think it's
so her
gone under the
kids can get
tire.
in the car and she can take them to school.
We can squish it!
She did a good job, but she's
That's a husband, isn't it?
like she just survived death.
Give me a hug.
Okay. If the audio didn't come up, then you can watch it on the slides. So social anxiety disorder. Okay, we're going to talk about social anxiety disorder a lot because we are going to see similarities of avoidant personality disorder when we get to that chapter. But for understanding social anxiety disorder, this is marked fear about one or more social situations, that the individual is experiencing fear of this possibility of scrutiny by others, judgment by others. And so being in social situations such as like having a conversation, being at a party, and what I call cold calling, right? Having to do the small talk component of it, meeting unfamiliar people. I think for social anxiety disorder, it can be like walking into a room full of people that they don't know, having to present a speech, having to do something where eyes are on them. And that fear of scrutiny and judgment is so overwhelming that it causes intense fear. It provokes that anxiety. It causes them to avoid that situation as much as possible, etc. But I'm sorry, I'm not trying to skip around with these particular of the order of the framework of these disorders. But ultimately, what this individual is fearing, in addition to negative evaluation and judgment, is that they're going to act in some sort of way or show anxiety symptoms, and that they're going to be that they're going to be negatively evaluated. So something is going to be humiliating, embarrassing. It's going to lead to offending others, is going to lead to rejection, that they're going to do something that's going to embarrass them, that other people are going to point and laugh at them, whether directly at them, that's the fear, behind their backs, but there's going to be some sort of negative evaluation if they do something that is humiliating. And I think that those really go hand in hand. Is that I'm inevitably going to do something, people are inevitably going to actually judge me as a result of this. And yes, so again, provokes fear, anxiety. What we can see in children is crying, tantrums, freezing, clinging, shrinking, failure to speak in social situations, even just like intense blushing, intense, like not showing eye contact, just like totally shrinking and hiding as a result of that fear of judgment or evaluation. I know I'm saying the word judgment. We don't actually see the word judgment in here, but that's really what that translates to. But negative evaluation is the clinical term. So this is where we see with social anxiety disorder, people are avoiding these whatever feared types of situations as much as possible. And if they have to experience them, they have that significant amount of anxiety or need a point person with them, need a parent, need a friend, to actually endure whatever contextual experience that they have to endure. But again, their fear is grossly out of proportion to the possibility of somebody actually negatively evaluating them. And I think like this is in so much of us talking to others about anxiety, even if they don't have an actual diagnosis of social anxiety disorder. I think a lot of people that have some sort of anxiety disorder have that come up of the fear of social situations. What we can do is typically reality test. It's like, well, how do you know what people are actually thinking? Do we have evidence that people are making fun of you? Do we have evidence that people are actually talking behind your back? Like, do we have any evidence that you did anything actually embarrassing? I know you're afraid of it. I know you don't want to do something and potentially put yourself in that situation, but even if you did, what would be the actual risk? If you upset somebody, can you can you get through that? Can you let them have their feelings? Can you work this out? Does it actually mean that this is true as far as something genuinely wrong with you? Usually we can drill into this and separate a person's fear from the actual reality. That's how we know it's really more so an anxiety disorder than what we see with avoidant personality disorder. But untreated, undiscussed, that person fears, no, the worst is going to happen. I'm not going to have any friends. Nobody's going to like me. People are going to judge me. They're going to talk about me. And the reality of that is that fear is really out of proportion to the actual situation. Was like most people are too focused on themselves and their own fears of judgment and evaluation to be worried about what somebody else says or does. Right? Is that fair? I think so. So ultimately, yeah, same kind of repeat of proportion, persistence, avoidance. You get the idea. We just need to look at if there are any rule outs to this. Is this happening as a result of any substances, medications, medical conditions? You know this. Is it better understood by panic disorder, by body dysmorphic disorder? For this, it's autism spectrum disorder. Is there some sort of medical condition that actually causes a person to contextually perceive that people are going to negatively evaluate them, right? Whether if they have a disability, if they have some sort of birth defect, congenital issue, something that's deformed, like is there actually contextual validity as far as why there's a concern to that? And so if that's the case, we wouldn't necessarily call it a disorder. But if any sort of, I'm looking at criterion J, if there is something that actually exists, this fear, anxiety, avoidance is really either unrelated or like grossly excessive. And that comes down to your clinical evaluation and judgment. Does this warrant a diagnosis of social anxiety disorder? Is it because of this? And how can I help a person endure potential discomfort of legitimacy as far as people looking at this medical issue, having questions about this medical issue? That's where a lot of exposure work comes into play. But we have to ascertain, is this legitimate? If other people were in this particular situation, would they experience the same kind of fear of negative evaluation or not? And is it grossly out of proportion to this? It really does warrant clinical attention. Now, for social anxiety disorder, we have a specifier that can be performance only, where people are not worried about particularly social situations. They're not worried about more of a generalized type of experience of being observed, meeting unfamiliar people. And it might be that it's really localized to performance, that, speaking, public performance, having to do anything on a stage with a microphone where people are staring. That's what causes that particular fear, anxiety, overwhelm. That's where we would label this as performance only specifier. So this can look like in the mindset of one that has social anxiety disorder. It's the fear that people are going to be like, this is the worst presentation ever. Nobody likes her. She's the worst. Her shirt is stupid. What a dumb question. Our minds run wild when we are anxious, and our minds are so good at convincing us that something absolutely will happen when we have no evidence that it has happened, that it will happen. And typically, if it does, these things are minor, they're transitory, people's emotions are fleeting. And so we can help our clients or our patients to be able to separate what is real versus what's imagined, what is fear versus what's fact, and help them to better endure situations while knowing, to help them better endure situations so that they can perform, they can connect with people, that they can do what they need to do socially, occupationally, etc. Panic attack specifier. This is laying the groundwork for understanding that panic attacks can show up and they can either be categorized under a disorder or categorized as far as just the existence of panic attacks. And so this is a specifier. This is really, again, like catatonia specifier. This is like peripartum onset, atypical features, anxious distress that we see in major depressive disorders. This is a way to be able to enhance an understanding of an existing anxiety disorder or obsessive compulsive disorder. So this is not operating in the context of its own standalone disorder. That's where we're going to get into panic disorder. So think about panic attacks as operating in two different ways, that they are categorized as expected, that more or less we know when they're going to come up, that we can really anticipate what triggers occur, and that could lead to an actual experience of a panic attack, or unexpected, meaning that this happens like out of the blue. Well, it's not really out of the blue, but we're not anticipating that somebody's anxiety is going to get that bad. Actually, yesterday at work, something really unfortunate happened to one of the nurses that I was supporting, and they were fearful that they were going to lose their job. They're not going to lose their job, but they were very fearful of it. And so their crying turned into total overwhelm and turned into a panic attack. I'm imagining that at the start of that particular conversation about what happened at bedside, that nurse was not thinking, I'm going to have a panic attack. But I was supporting this person, and afterward, and they had gotten out of the panic attack, because what we'll learn is that panic attacks really just occur for a short period of time. Unlike what some people say, where it's like, oh, I had a panic attack for hours. It's not a panic attack. That might be a heightened level of anxiety, just a heightened level of overwhelm and distress, but not technically a panic attack. But in me talking to this person after they were able to be more regulated, I learned that they have a lot of other anxiety. There's contextual, situational overwhelm. They've been an anxious person for a long time. I think they have probably not generalized personality disorder, generalized anxiety disorder. And so that creates more of a proneness to panic attacks, for instance. It creates more of a proneness to overwhelm. And when I think about panic attacks, this is when the mind is basically in such distress that the body completely goes into shutdown mode, like in a very uncomfortable way, where it feels like they're going to die. And so ultimately, to define a panic attack, this is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, so not hours, reaches a peak within minutes, during which time we see four or more of the following symptoms. We see this abrupt surge that can come from a calm state or an anxious state. We see palpitations, pounding heart, accelerated heart rate. So there's cardiac issues that can make people feel like they're having a heart attack, actually. Sweating, trembling or shaking, sensations or shortness of breath, or like they're being smothered, like they can't breathe, feelings of choking, chest pain or discomfort that goes into the palpitations, the pounding heart, nausea, abdominal distress, feeling dizzy, unsteady, lightheaded, or faint, chills or heat sensation. So having one or the other, I don't know if both, numbness or tingling sensations, parathesis. Oh my gosh, I need to pronounce that. Derealization, which is feelings of unreality, or depersonalization, being detached from oneself. We'll talk about this next week. But derealization is that, like, you're in this kind of dreamlike or really alternative reality state. Depersonalization is you're being disconnected from your body. That overwhelm, that just paralysis is so distressing that you're not even in your body to experience it. Moreover, the fear of losing control or going crazy, the fear of dying. We can also see or experience tinnitus, so the ears ringing, neck soreness, headache, uncontrollable screaming or crying. That can be seen too. It's not part of the diagnostic criteria, but I do really see crying as kind of a precursor, and that was what was happening with this nurse. Started crying, couldn't breathe, started hyperventilating, and what I find is that those that have experienced panic attacks, I mean, anybody who's experienced this can attest to how uncomfortable it is. You don't know what's going on. You think that it's a major medical issue. People end up in the emergency department because they're worried that something bigger is happening. But that proneness to overwhelm can also lead to a high attunement to what's happening in the body and can kind of really perpetuate the experience of a panic attack that can lead to that heightened degree of listening to the body so much that it causes more anxiety and can peak with this abrupt surge of anxiety, this intense fear, discomfort, this essential panic attack. No, this overwhelmed acute state. That's what I'm trying to say. Okay, so what was the other thing I was going to say? Panic attacks essentially function as a marker and can be a prognostic factor for the severity of a diagnosis, which means that we can tack it on. So, if a presence of panic attacks, we can tack it on to generalized anxiety disorder, to specific phobia, to social anxiety disorder, and can essentially tell the reader, hey, there are times where somebody's anxiety is so bad that it can turn into panic attacks. And it can speak to just the potential for comorbidity and across disorders, and this can speak to the presence of substance use, depressive, psychotic disorders. That panic attack is the indication that something is really, really wrong. This is the distress call, the distress signal that something bad is happening for the individual. And so that's where we would identify the panic attack specifier, and we would use that. Let's see. And I mean, we could tack this on. It does not have to be anxiety disorder or OCD disorder specific. We could say somebody has major depressive disorder with a panic attack specifier, or PTSD with panic attacks. So you can use this across contexts diagnostically. It does not have to be for these particular chapters. And so examples of anxiety diagnoses with panic attack specifier would be social anxiety disorder, performance type with panic attacks, specific phobia, situational type with panic attacks. What's different in the options that we have is we don't have the severities like what we see with major depressive disorder, with bipolar disorder. We don't have the severities of mild, moderate, severe, right? We just have essentially the nuances of how this shows up and how intense it gets. I hope that makes sense. Okay, so we're going to look at panic attack specifier versus, and here's another visual of somebody experiencing a panic attack. Just all the different ways that it can show up in the body. Like I said, distress, like all the lights in your dashboard are just totally are indicated, flashing. That's the word I'm looking for. I swear it's hard to speak coherently, to speak clearly, to pull out all this clinical information and to sound like I know what I'm talking about. So there are times where I have a glitch in the system and I'm like, where am I? What am I doing? Okay, back to normal, back to life. Here is a visual demonstration of where different elements of the panic attack can live in a person's body. And again, remember, short period of time. We usually think about like a panic attack lasting like 5-ish minutes at most. And that is a long time for somebody experiencing this. Typically, what we need to do is ground them as soon as possible. But like 5 minutes, 10 minutes is a long time for somebody to feel like they're choking, they're going to die, that something's wrong with their heart, that they have numbness, tingling all over their body, that they're feeling like they're being suffocated, right? Like 30 seconds would be a long time. So that's what I want you to think about. This is an acute state. This is an acute experience. Okay, so intentionally repeating myself with panic attack specifier. What it actually does not specify is whether the presence of panic attacks are categorized as expected, unexpected. For the sake of the specifier, it doesn't really matter. We are just using this as an opportunity to further elaborate on the nuances, the intensity, the severity of a person's pre-existing disorder. If we want to focus solely on the effect that the panic attacks are having on a person, this is where we go into panic disorder. And so the difference between the presence of expected or unexpected attacks versus panic disorder is that for panic disorder, in order to meet criteria, we have to see recurrent unexpected panic attacks. So the criteria of what a panic attack looks like in this disorder is still the same, but the nuance is that they have to be unexpected panic attacks. That's what causes more distress. That's what causes more overwhelm. That acute state is the same. So we see a re-explanation in criterion A that is a repeat of what we see in the panic specifier section. Now, what makes it a disorder is that at least one of these unexpected panic attacks has been followed by 1 month or more of both persistent worry and concern about additional attacks. And as a result of that persistent worry and concern, a person is actively avoiding situations that could create more unexpected panic attacks. Okay. So, what the textbook says is that a significant maladaptive change in behavior related to the attacks, i.e., behaviors that are designed to avoid having panic attacks. So, if you got a panic attack, when you exercise, no. If you have had unexpected panic attacks and the overwhelm of heart rate increase, not being able to breathe is so much that you don't want it to potentially trigger a panic attack, then a person may not exercise, right? So they're not going to put themselves in a situation that is going to trigger that physiological response that they experienced when they had that unexpected panic attack. But there might be contextual situations or environments that they avoid if they know, hey, the last time that I experienced this panic attack, I was in this situation. So I do not want to be in this type of social, occupational, whatever type of situation again. So I'm not going to put myself in that situation. So why this disorder is a disorder is because having an unexpected panic attack is so distressing that as a result of one or more of these unexpected panic attacks, we see a period of 1 month or more where that person is in a fear of the panic attack recurring, right? Of having additional panic attacks or their consequences. So losing control, that's a big one, having a heart attack, going crazy. And then again, we see a maladaptive change that looks like avoidance that's designed to prevent further unexpected panic attacks from occurring. Okay, so again, so criterion C is looking at, is this actually a medical condition? Is a person sweating, trembling, shaking, shortness of breath, fear of choking, heart rate increase, abdominal stress? Is that actually a medical condition and that's what's causing distress? Or is this really better explained by exposure to particular circumstances and that really needs to be a specific phobia? You can read through this, but it's a matter, is that a standalone diagnosis or does this speak to the impact or the expression of a diagnosis like specific phobia, like separation anxiety? Is the panic attack really the distress component of this? But I don't know. Crying and fearing being separated by your attachment figure is is a little bit different than what we actually see in a panic attack. So I think that it's more notable when you can actually point out a panic attack, be like, no, that was a true panic attack. This is not just distress over separation from key attachment figures, for instance. Okay, so for panic disorder, how many panic attacks need to occur and what type of panic attacks do they need to be? We see recurrent, i.e., one or more unexpected panic attacks in order to meet criteria. Now, if a person has only expected panic attacks, does this meet criteria for the disorder? No, the panic attacks have to be unanticipated and unexpected. Although any panic attack is still distressing and we can use it as a specifier to another diagnosis. If you don't know what the other diagnosis is and you just know that the person is having panic attacks, then you could go with an unspecified anxiety disorder with panic attacks as a provisional while you're really trying to work out what the specific anxiety or OCD disorder is, for instance. Last question, what's the functional impairment component of the unexpected panic attacks and over what period of time? Okay, so this is looking at criterion B, criterion C. I can't remember now. B. As a result of the unexpected panic attack experience, at least one of these types of attacks has been followed by 1 month or more of that persistent worry and concern about having additional attacks and that maladaptive behavioral change. I will take avoidance in order to prevent future attacks, okay? So I hope it makes sense. If you have questions about this, don't hesitate to ask in class. We will go over this. But then the last question I ask here that I don't actually give you an answer of, why is there a difference between the panic disorder and panic attack specifier? Panic attack specifier is distressing, but it does not necessarily cause impairment in one's life. It's not enough to actually cause distress in an ongoing way and impairment in one's life. When we talk about distress over the attack, distress over the fear and the worry about having additional attacks, and then avoidance, situational avoidance, that the pathways of their lives are changing because they are trying to prevent future attacks. That's what makes it a disorder. Make sense? That's why we need it to be in its own separate category. Okay, agoraphobia. I'm not getting excited about this, but we are coming up toward the end of our anxiety disorders section. Now, agoraphobia actually, fun fact, used to be a specifier in the DSM-4. And it was very similar to the panic attack specifier, and it was actually tacked on to panic disorder. And it was either panic disorder with agoraphobia or panic disorder without agoraphobia. You could not diagnose agoraphobia on its own. What's interesting, I have this right in front of me, okay. So what it talked about was the experience. I'll get to it. I'm going to get to it. In the diagnosis of agoraphobia, as it is in the DSM-5, what we see is that there's a marked fear or anxiety about 2 or more of the following situations: using public transportation, planes, trains, automobiles, ships, etc., being in open spaces, parking lots, marketplaces, bridges, being in enclosed places, shops, theaters, cinemas, the grocery store. I know it says marketplaces. That's really meant to be like a broader, bigger cultural marketplace. So being in enclosed places, standing in line or being in a crowd, being outside of the home in itself. Okay, now that part, criterion A, is not in the DSM-4. The DSM essentially created more of an elevated understanding of how agoraphobia is different than panic disorder. Panic disorder, we see ambiguity as far as what the person is avoiding. What they're avoiding to make sure that they are avoiding a potential panic attack. Agoraphobia has escalated, has graduated to a more crystallized presentation of avoidance. And so not only do we see the difference between, well, you just need to be avoiding something, to no, you have to be avoiding two particular situations in order to meet criteria for this disorder. The commonality, this is really the conceptualization of what agoraphobia was and is that the reason that these situations are avoided is because a person perceives that they're going to have a panic attack or that something really bad or embarrassing is going to happen to them. And as a result of that, they are not going to be able to get out of that situation. Or if they have to get out of that situation, it's going to be incapacitating, embarrassing, it's going to be uncomfortable. So let me explain this. If I'm worried about judgment, about scrutiny, if I have panic attacks, etc., in my mind, it's either been really uncomfortable physically, it was a bad situation in reality. But in my mind, I'm like, I don't want to go through this again. I don't want to experience this again. I don't want to be in a situation where I'm going to have another meltdown and people are going to stop what they're doing. They're going to come over to me. They're going to be asking me questions. Everybody's going to be staring at me. That is too much to handle. I'm never going grocery shopping again. If I have to go, it's going to be the worst experience ever because I'm just going to be so terrified. But so the context of this is that somebody's anxiety about being anxious is so heightened that they're fearful that they're going to have an episode, they're going to have a moment, something bad is going to happen to them as a result of being in these situations, and that trying to get out of that situation, trying to endure this is going to be really, really embarrassing. It's going to be incapacitating. It's going to be uncomfortable, right? And so what I'm explaining this from memory, but what the DSM says is that the individual fears or avoids these situations because thoughts that escape might be difficult or help might not be available in the event of developing panic-like symptoms or other incapacitating or embarrassing symptoms. So what this also says is that, elderly might be fearful of falling, or somebody that has incontinence, so they aren't able to, they need a diaper because they can't manage their bladder or can't manage their digestive system. And so having an accident in front of people, trying to get out of that, is so terrifying. What that criterion B is saying is that that's the fear. That's that marked fear, anxious situation that somebody is trying to avoid because it causes such potential distress at the thought of it happening. So as a result of this, they avoid two or more situations. That's where we go back to criterion A. I hope that makes sense. But we see that agoraphobic situations almost always provoke fear or anxiety. They're actively avoided. They require the presence of a companion, or they're endured with intense fear or anxiety. If they have to be in a public space, they have to be standing in line, they have to be outside of the home at all, being in an enclosed space, whatever that is. And again, this is happening for 6 months or more. If there is a medical condition, I'm looking at criterion H. If there is a medical condition, that experience is the fear, anxiety, or avoidance is really excessive and outside what we would see for a normal reaction to that particular medical condition. And again, we have to rule out, is this related to something else? Are we only seeing this in particular situations and not across the board in two or more situations? So is it confined to a specific phobia? Is it confined to social situations? Is it really related to obsessions in OCD? Does this really better speak to the nuance of a particular type of disorder versus, is this person incapacitated in a lot of general situations that we would be in being out in the world? Again, because fear of escape might be difficult, help might not be available, or it's embarrassing. So that's what I want you to think about, is like, I'm going to be stuck. People aren't going to be able to help me. They're going to be staring at me. Like, this is going to be a really bad thing, and I don't even want to have to deal with that. Okay. What the note says at the bottom of this disorder is that agoraphobia is diagnosed regardless of whether there's a presence of panic disorder. So this is breaking away from the DSM-4 chains, and this is speaking to, you might have panic attacks, you might have panic disorder, but if it is so pronounced where you are not only avoiding one situation, but you're avoiding more situations, we're going to assign agoraphobia. If they meet criteria for panic disorder with the presence of panic attacks, that's where we can actually diagnose both. We can diagnose panic disorder and agoraphobia. Panic disorder is talking about, really, I'm going to avoid this because my panic attacks are so intense. I don't want to experience the panic attacks. Agoraphobia is like, panic-like symptoms are so intense. I don't want to be stuck. I don't want to be the center of attention. I don't know who's going to attend to this, and I don't want to deal with it. Okay? Does that make sense? I hope it does. Maybe I'm just saying this ad nauseum and you're like, Lindsay, I get it. Move on. So ultimately, the cheat sheet on this slide is that we have to have fear of 2 or more situations: public transportation, being in open spaces, being in closed places, standing in a line or in a crowd, being outside of the home in itself. So thoughts such as, I shouldn't have gone outside by myself. This happens nearly every time I leave. First, this line of people terrifies me. I can't navigate it. And after that, I'm about to get on a bus. I'm totally frozen. What if I get too anxious? And what if I try to get off, but I get trapped inside? Instead, what if these people laugh at me? That'd be so embarrassing. I don't know if I'm going to how I'm going to handle it. This is why I never leave. I'm terrified and I want to go home. These may not be actual thoughts that people can connect to, but again, it's the idea of the feeling of the thoughts. It might be a running dialogue that somebody's having in their mind, but it's what that translates to and how that cognition really increases the fear and affects one's behaviors as a result of it, going back to that cognitive triad. So lastly, in the anxiety disorder section, we're going to talk about generalized anxiety disorder. It's very interesting to me that this is the most common of the anxiety disorders, yet this really comes last in the chapter. But here we are. Generalized anxiety disorder, as I said, this is going to be something that we see much more notably. It is a foundational disorder in this chapter. And it is often, I think, misunderstood. We assume that generalized anxiety disorder is one thing, and I find that it's very helpful to be able to really connect with the 6 different symptoms associated with the anxiety and the worry that comes in this disorder. I will get to that in a second. But yeah, so breaking this down, generalized anxiety disorder, what I really want you to think about is this is excessive anxiety and worry, i.e., apprehensive expectation. I love that. I think that term speaks so helpfully to the condition, the experience of generalized anxiety disorder, this apprehensive expectation, again, of things going badly. Okay. I'm adding that in for your conceptualization of things going badly. I'm apprehensively expecting the worst. Again, not danger necessarily, but bad things. I'm expecting to let people down. I'm expecting disaster, calamity. I'm expecting overwhelm. And that's causing me dread. That's causing me a general deep sense of worry as a result of this. So that condition occurs more days than not for at least 6 months about a number of events and activities. It's not just, I'm really worried about this test and I'm very, very worried and overwhelmed about this and what this is going to look like. That was me with my licensure exam, where I had 7 months that I studied and I had a lot of worry about passing the test. But I didn't have generalized anxiety disorder because I wasn't worried about other things. I was like remarkably cool, calm, and collected. I was just worried about that one thing. So that's an example. If you're like, well, what if you're really, really worried about one thing? This disorder talks about it being about a number of events and activities, really kind of not indiscriminately, but the potential for it to be jumping from one context to the other, from one concern to the other. So this can fall under the categories as work, school performance, life, family, the relationships we have, etc. B in this criterion is the individual finds it difficult to control the worry. So we have excessive anxiety and worry for more days than not for 6 months. And as a result of this, the individual is finding it difficult to actually control and manage their worry. This worry, this anxiety, is associated with 3 of 6 different symptoms that have been present more days than not for the past 6 months. If we're talking about diagnosing this in children, only 1 item is required out of 6, okay? So in association with this general present anxiety and worry, we see factors such as, or symptoms, such as restlessness or feeling keyed up or on edge, being easily fatigued, difficulty concentrating or one's mind going blank, irritability, muscle tension, and or sleep disturbance, i.e. difficulty falling or staying asleep, or restlessness or unsatisfying sleep. Okay, so we need to see 3 of these 6 symptoms to meet criteria for generalized anxiety disorder. And as we know, the anxiety, the worry, the physical symptoms can cause clinically significant distress, social impairment, functioning issues, occupational issues, etc., right? And so think about these 6 symptoms: the restlessness, being easily fatigued, difficulty concentrating or one's mind going blank, irritability, muscle tension, sleep disturbance. What happens in our bodies when we get stressed, when we get anxious, when we're dreading something? We tense up, right? Get restless. We hold this tension, and depending on who you are, in our shoulders, in our chest, in our stomach. This affects the way that our mind works, right? Just kind of go offline. We have a hard time concentrating. It might be that we're going from one thought to the other. We're just perseverating on what we're worried about. Irritability, I think, is a very common expression of generalized anxiety disorder, is that we get irritable because we can't figure something out, because we fear losing control, because we're preoccupied, because we're I've heard this described, and I've heard it described so well, with the idea that anxiety is like a rocking chair. We just keep Let me rephrase this. Anxiety is like a rocking chair. It gives us something to do, but we don't get very far, right? We keep sitting in it. We keep moving in this anxiety, but we're not going anywhere. Just stirring, recycling, spinning, but it's not giving us more clarity. It's not giving us an opportunity to do things differently. That's really how we know that this is anxiety, that like we're saturated in our worry, is that it's living in our minds. We can't manage it, and it's affecting what's happening physiologically for us. So that's why we can't sleep. That's why we have muscle tension. The irritability, I was saying this, the irritability is like, I've got to figure this out, but I can't. Or like, I'm just so tense, leave me alone. I think there's a lot more to be said about this. That it's like, I can't stop thinking about this, and it is overwhelming to me. Just please let me be free from this distress. Please let me be free from the prison of this worry. Right? That's relatable, unfortunately. So that's generalized anxiety disorder. We have to make sure that this is not part of a bigger disorder. And I think the notable components of the rule outs are that's not part of OCD. It's not part of social anxiety disorder. It's not part of reminders of traumatic events. Like, we definitely see anxiety. And when we talk about PTSD, there's a lot of similarities, but the bigger thing is the exposure to a life-threatening situation is very different than I'm fearful that something, or I'm anxious that something bad is going to happen. It's like, no, something almost did or it did. Okay, so that's generalized anxiety disorder. Now in this slide, if you're listening, in this slide, I just have on the top part of the slide is the same girl that is chewing biting her nails, sweating with a very tense look on her face. So breaking this down, reiterating, excessive anxiety and worry is, again, occurring more days than not. This is expressed as apprehensive expectation for at least 6 months about a number of events. So it's like, what if I get cancer? What if I lose my job? What if my friends really don't like me or don't really like me? What happens if I gain weight from going on vacation? What happens if I take care of myself? Oh, how would I take care of myself if I lose my job, if I lost my job? And then just visual reminders of restlessness, being easily fatigued, difficulty concentrating, mind going blank, irritability, muscle tension, and sleep disturbance. And I think that's also a really common experience of, like, the mind keeps racing. We can't quiet it down. We're just so anxious and so worried and distressed about something bad happening that we are dreading, right? That's the apprehensive expectation. I have two assessments shown for you here, the BDI, the Beck Depression Inventory, and the GAD-7. The BDI, gold standard as it relates to scoring for one's experience with an anxiety disorder. But it's 3 pages. It can be long. I love the GAD-7. I think it's really easy to score. It gives somebody a snapshot of, this is what I do for all of my clients in their intake sessions. It gives a snapshot of where they are as far as experiencing stress. And it has 7 questions. And it's really the symptoms of generalized anxiety disorder: feeling nervous, anxious, or on edge, not being able to stop and control your worry. Oh, it's not really the symptoms, just kidding. Worrying too much about different things, trouble relaxing, being so restless it's hard to sit still, becoming easily annoyed or irritable, feeling afraid as if something awful might happen. It does not talk about the sleep issues. It does not talk about muscle tension or does it have difficulty concentrating? It doesn't have difficulty concentrating. It's really the overarching themes of, I stand corrected, overarching themes of the anxiety disorder with a couple of factors of having a hard time relaxing, restlessness, and irritability. So kind of half of them. Okay, so here is the conceptualization of obsessive compulsive and related disorders. We're going to switch gears, new chapter, some crossover of OCD as we go through obsessive compulsive disorder in itself, hoarding disorder, body dysmorphic disorder, and trichotillomania and excoriation disorder. What we see on the slide speaks to both the cognitive component and the behavioral component of OCD or obsessive compulsive disorders. And so we have this infinity type of signal or symbol, pardon me, that talks about the interplay between intrusive thoughts and compulsions. And so just per the DSM, compulsions are defined as repetitive behaviors or mental acts that an individual feels driven to perform. And this can be voluntary or seemingly feels like subconscious, driven to perform in response to an obsession or perception, which is according to rules that must be applied rigidly. So these very specific beliefs that come from intrusive thoughts. So going back to this cognitive component and intrusive thoughts, that's the obsessions aspect of obsessions and compulsions in obsessive compulsive disorder. Duh, Lindsay. So intrusive thoughts or urges, preoccupations, and perceptions of beliefs. Ultimately, these are overwhelming, distressing thoughts that come up. We see this specifically in OCD. Urges to do something or significant fixed preoccupations or perceptions, so like fixed beliefs about something. I'll get into this as we get into the disorder specifically. But what happens when we have these thoughts that come up involuntarily that speak to beliefs that we have to do something the right way, these urges to perform checking behaviors, these urges to clean, these urges to hold on to things, these urges to pick, these urges to look at our bodies, these beliefs that we're not, but our bodies are one particular way when they look actually different in real life. This is a key component of obsessive compulsive disorders, is that we have almost these fixed delusional beliefs about how something is or what we're supposed to do. That causes us anxiety. The presence of intrusive thoughts, urges, preoccupations, and perceptions cause us anxiety. We don't know how to manage it, can't make them go away. These thoughts and feelings are very, very, or these thoughts are really overwhelming. And as a result of the anxiety that comes from the cognitive component, we have this behavioral component, which is demonstrated through compulsions or repetitive acts. Again, these are designed to reduce anxiety. They can be time consuming. They feel like, in response to this belief that I have, in response to these thoughts that are coming up to me, I have to engage in this practice until those thoughts go away, or until I've really satisfied what these thoughts are telling me to do. I know this is sounding a little bit vague right now. I will break it down in the subsequent disorders. So, with regard to obsessive compulsive disorder, we have the presence of obsessions and compulsions, or both. Obsessions being defined as recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individuals, they will cause anxiety, marked anxiety and distress. Now, as a result of having these recurrent and persistent thoughts, urges, or images that are experienced that are unwanted, distressing, what the individual will do is they attempt to ignore or suppress the thoughts, urges, or images, or to neutralize them with some sort of thought or action. Hence, enter the compulsion. The compulsions are defined by repetitive behaviors such as hand washing, ordering, checking, or mental acts such as praying, counting, repeating words silently, things that are repetitive, things that have a very rigid structure, that the individual feels driven to perform in response to the obsession or according to rules that must be applied rigidly. And there's not necessarily like a rule book where this comes from. This is what's happening at a cognitive, emotional, behavioral level for that individual. It's happening like at a subconscious psychological level for the individual. And the behaviors or mental acts are aimed at preventing or reducing anxiety or distress or preventing some dreaded event or situation. However, these behaviors or mental acts are not actually connected in a realistic way with what they're designed to neutralize and prevent, i.e., they're not connected to necessarily to the intrusive thought, to the urges, or if they are, they're clearly excessive. And then the note here is that young children may not be able to articulate the aims of these behaviors or mental acts. Because the reality is that takes a lot of insight, right? It takes a lot of insight to be able to connect with, these are the thoughts that I'm having. They come up over and over again. They won't leave me alone. This is like what I think I'm supposed to be doing, why I'm supposed to be doing it. And in order for me to feel better, in order for me to feel like I'm doing it right, these are the things that I have to do to complete the process. That is something that, depending on the child, depending on the adolescent, depending on the adult, really does require a lot of insight to be able to put those pieces together. And so this is what that note really speaks to. I'll give you an example of with the compulsions defined by the mental acts are aimed at preventing or reducing anxiety, but they're not necessarily connected in a realistic way to the very intrusive thoughts and urges that they're designed to prevent. I had a patient a long time ago at Sharp Mesa Vista who had long-standing intrusive thoughts about hitting her mother over the head with a mallet, like cartoon style. I'm having deja vu that I already spoke about this in a lecture video, but like that she would come up from behind and whack her mom on the top of the head, and then she'd kill her mom. And so as a result of how these intrusive thoughts impacted her, and I didn't treat her at the beginning of this process, but I think that intrusive thought, that obsession, was a very long-standing obsession that had probably come up in her 20s. She had a difficult upbringing, but genuinely did not want to cause her mom harm. So as a result of these obsessions, what she had developed were compulsions to engage in hand washing, counting, and checking behaviors. And there was this whole system that she engaged in of washing her hands, of I know this sounds like totally stereotyped, but this is what I remember of checking her appearance in the mirror, and she'd leave and then come back and have to check it, and then leave and have to come back. And I think there's like one other thing about it. And there was a lot of counting, like a lot of really specific, rigid, and ritualistic behaviors that she had engaged in. And so, these behaviors have nothing to do with whether she will or not, or whether she will or won't hit her mother over the head, right? But it's what made her feel better in the moment. It's what essentially, I think her belief was, if I do these, then I won't actually hurt my mom in real life. That's not logical. Doesn't make any sense. But that is one story of many stories of I have these overwhelming thoughts that pop into my head. It's the same thought or a similar thought. I don't know how to get rid of it. It's totally terrifying. I'm very worried about it. And so as a result, these are the things that I need to do to make that thought not turn into reality. These are the things that I need to do to make that go away. So that's an experience of the relationship between what obsessions look like and how compulsions play out, with the intention of preventing bad things happening, managing those urges, and reducing one's distress and anxiety as a result of it. The other factor that we know that goes in, or the quality and experience of these obsessions and compulsions, are seen in criteria B, or criterion B, where it states that the obsessions or compulsions are time consuming, i.e. they take more than 1 hour per day, or they cause clinically significant distress or impairment, right? And so that can be very much the focus in what we see from a clinical perspective, is that they take time. It really, at worst, can be something that takes up the majority of their day, or it really shapes their behaviors, that things are avoided, behaviors are expressed in such an excessive way that a person does not feel right, or does not feel like they're doing it perfectly unless they do this the right way. And there's rigidity around what the right way is. And so there's just a very deeply held sense, or deeply held belief about how this relationship between obsessions and compulsions needs to go. And not being able to do that causes extreme distress and overwhelm. I think there's one slide that's not showing up that I have to unhide. But with OCD, we see this interdependent relationship between obsessions and compulsions. And I have a whole table here of what this can look like. What we know is that we don't actually um, see pure, I actually don't have this on here. We don't typically see pure O, which is just pure obsessions. That usually there is some sort of corresponding compulsion that goes with the obsessions. And what we also know is that typically these intrusive thoughts, these urges, these preoccupations are not actually aligned with the person in their waking self. They're not necessarily like aligned with the person's genuine thoughts, feelings, or beliefs. I go back to my patient at Sharp Mesa Vista, who I think was like, yeah, I had a really bad childhood, but like I don't want to hurt my mom. I don't want anything to happen. And these obsessions can really involve magical thinking, the obsessions and the compulsions. If I don't do this, if I don't engage in this, then something bad actually will happen. That we have magical powers to be able to, you know, engage in practices that are extraordinary, or to be able to inflict harm from afar. So, or like, if I don't check this thing, if I don't count this, if I don't wash this, if I don't watch this, then a different place in the world, lightning is going to strike this person, right? I'm just using a very generalized example, but it's this belief that if I don't do this one thing over and over and over again until it's just right, or done the right way, then something bad will happen. This used to be known as the doubting disease. Did I actually do this enough? Did I do it long enough? Did I, like, is everything clean, or am I doing it the right way? This doubting disease is basically like, I doubt that I fixed this. I doubt that I handled this. I doubt that this is right. I doubt that this is something that is going to be, that I'm going to be free of. So what we see, and this is like, I doubt myself. So what we see is an example of Lorena spends 30 minutes checking every email before sending it out of fear of saying something offensive, even though she has never said something offensive at work. So different examples of obsessions can be contamination, accidental harm, relationship OCD, religious-based scrupulosity, unacceptable taboo thoughts about sexuality. So with contamination, it can be fear of getting sick, being dirty, getting others sick. We definitely can see compulsions that are related to this show up through washing hands, washing oneself, showering for extended periods of time, brushing teeth for more than 5 minutes, cleaning every surface of the house, and then you need to do it all over again because you breathe on it wrong, that kind of stuff. Accidental harm, so fire, hit and run, pushing someone down the stairs. Again, this like intrusive thought of inflicting harm indirectly or directly onto somebody. The checking behaviors can show up as far as checking the stove, checking locks, doors, windows, or appliances multiple times. Also, we can see compulsions of symmetry. So arranging, counting, what we call just right OCD, is I have to count until it feels just right, or I have to get the right number, or I have to arrange this in just the right way. And then there's this like temporary sense of peace, of relaxation, and then the intrusive thoughts come up all over again. Relationship OCD, fear of partner cheating, being alone, making the wrong decision. That can show up as far as compulsions of texting, checking, excessive reassurance, all of this compulsively, excessively, asking the same question repeatedly, checking emails repeatedly, just being stuck in this like, am I doing this right? Am I doing this enough? What do you think about this? I can't handle this. I have a client in my private practice that I'm still trying to figure out if they have OCD. But it would be relationship OCD. And when I started working with them, it was a lot of reassurance seeking. And what we figured out is it's just this fear of making the wrong choice. And my client is getting better now, but is continuously paralyzed by this perception, by this fear that they're going to end up alone, that they're going to make the wrong decision, that they're not going to be happy. And as a result of this, they engage in like, at first it was really very excessive, and we've worked it out and gotten it to be more manageable. But just constantly asking me, what should I do? Should I send this? Should I not send this? What do you think about this? Like, asking ChatGPT for hours on end, and ChatGPT was like, you need to get a therapist, bro. I laughed so hard when he told me that. I was like, well, what do you think? Like, what do you think? I was like, that's why you're here. Anyways, yeah. that can happen in a compulsive way. Religious-based scrupulosity is this fear of being unclean or not pure, fear of going to hell, fear of being gay. Some sort of shame or harm can come to a person if they don't practice in a particular way. That's really the magical thinking. We can see this show up as far as excessively praying, attending church, saying Hail Marys repeatedly, chanting other excessive practices, etc. And then unacceptable taboo thoughts about sexuality. This is a real one as far as obsessions. This taboo thought about being gay or sexually assaulting someone. I was surprised to learn that that's actually a really common intrusive thought. And mental rituals, again, excessive reassurance seeking. I once had a client who did not have OCD, had generalized anxiety disorder, but I once had a client who, after not having seen them for a few months, had texted and they were like, I really need to come in. I'm getting very overwhelmed with something. And they came in and they said, hey, I think I'm gay. I was like, why? And they said, well, because I think I'm having a lot of intrusive thoughts that I'm gay. And so I'm like, well, what are you doing? How are you managing this? And then he said, well, I'm watching a lot of gay porn to see if I get aroused. It's like, what? And he said, yeah, like I've been trying to see if like that's what will trigger my awareness that I'm gay. And I don't know, I could have done things a different way, but I just remember like off the cuff, I was like, well, what would be the worst thing about being gay? Like, why would that be bad? And he's a strong ally. He has no problem with. This makes me sound. He would not have had a problem with it. He would have been fine with it. And then he reacted in that way. He was like, "Oh, there's no problem." It's like, "Oh, okay." And then he stopped doing that. He stopped with the intrusive thoughts. He stopped watching gay porn. So this like blip of managing these obsessions through these compulsions. That were very time consuming when they happened. It's fascinating. Here's another slide of signs of OCD. Common obsessions include contamination, causing harm, making a mistake, socially unacceptable behavior, fear of thinking evil, sinful thoughts, need for order, symmetry, exactness, excessive doubt. Let's see, abnormal concerns about sticky substances. We talked about that. Yeah. Common compulsions. Let's see that we didn't talk about. Distress when objects aren't facing the right way, eating foods in a specific order, blinking or staring rituals, repeating specific words, prayers, or phrases, needing to perform tasks a certain number of times, collecting or hoarding items with no apparent value. We'll talk about that. And the need to touch, rub, tap certain objects repeatedly, excessive list making. Oh, I forgot about that. That is a big one. I've treated a couple of different clients over the years that engaged in list making. And the first one that I treated, I had no idea that it was OCD. Like I thought it was generalized anxiety disorder. I knew it was a coping, but man, they had so many lists because that's what seemed to fix the fear and overwhelm that they were going to be out of control, that they weren't going to be able to handle the day-to-day responsibilities. And so they'd write lists down, and that became the compulsion. Is in order for me to feel better and for me to feel like I can handle this, I'm going to make lists. That was very debilitating in itself. On this slide in the lecture, you can click on this link. It says HBO episode of OCD, and it's a clip about the show Girls. And Hannah, the main character, has, well, she's not a living person, but had OCD. And so it's interviewing, I think, a therapist talking about the reality of this and the accuracy of that presentation. It's a little graphic because she talks about masturbation, but it, I think, gives a very clear demonstrative, it's a very clear explanation, not just about masturbation, but a clear explanation of what the other rituals, checking behaviors, blinking, counting, that kind of stuff, the just right behaviors looked like as a result of, I can't remember what the intrusive symptom was, but as a result of the cycle. Okay. So here is on this slide is just another breakdown for your visual, for your learning needs of the obsessions. So again, recurrent and persistent thoughts, urges, or images that are intrusive and unwanted. As a result of having these, the individual attempts to ignore, avoid, and suppress in order, or doing something to be able to neutralize with a particular action that they perform. And in this experience of these recurrent thoughts, urges, and images, that it creates anxiety. So the individual attempts to ignore, avoid, suppress, and then we enter in the compulsions that are aimed at preventing or reducing anxiety or distress, preventing some sort of situation from happening that's dreaded, but they may not be connected in a realistic way. And if they are, they're clearly excessive. Because the message really sent to the brain in this state of mind is that you have to keep checking in order to make it better or to feel better. It's this vicious cycle of, in order for me to do this thing that makes this obsession go away, I have to engage. It's like a really powerful distraction tool, but ultimately keeps that person stuck and reinforces, in order for me to feel relief, I have to do it, and I have to do it this way. And so we know that relief comes after that, but it's temporary. This is the sensory phenomena, is what it's called, is that this relief, this, okay, I did it the right way. I did it. But this is temporary, right? We know that this does not actually stop intrusive thoughts, urges from showing up subsequently. So another slide just about the cycle of like checking the stove, of I'm going to accidentally set my house on fire, everyone I love will die. And that painstaking process of, did I check it? Did I turn it off? I think I did, but what if I forgot someone? What if I forgot something? I have to keep checking. I didn't do right. I need to go back, because what if the burner turned on and I didn't see it? Or like, I have to turn these on and off, and then that will make me recognize that I've done it the right way, so that this won't actually catch fire. But then that intrusive thought of like, well, what happens if I didn't do something right? What if I miss something? That's the doubting disease. What if something goes wrong? What happens if this experience, or something catches on fire anyways? It's exhausting. So what's new on here that I haven't spoken to is that we get to specify if somebody has a particular degree of insight, or we get to specify someone's degree of insight. We have to specify someone's degree of insight, is what I'm trying to say. Is it good insight or fair? Is it poor insight, or is it totally absent, almost delusional? Did I leave this up here? I'm back on the slide of the actual DSM diagnosis. The good or fair insight is that these beliefs, the experience with the compulsion is probably not true, and that it may not be true. Definitely, probably, or may not be true. Poor insight is, it's like, no, I think that my beliefs, my thoughts are true. I think that this is probably going to happen. Absent insight or delusional beliefs is like, no, this process is absolutely accurate. I have to do it no matter what you say. This is the only thing to cure this thing that I'm worried about, this thing that I'm fearful of. Okay. Body dysmorphic disorder. We're going to talk about this in our eating disorders section, but ultimately, because we're going to tie this into eating disorders, what this is it's a preoccupation with one or more perceived defects or flaws in a person's physical appearance that are not perceivable, or if they are very slightly perceivable to others. And so this is where somebody is perceiving that and we can see this from like one body part, multiple body parts, the whole body. We can see a specifier of muscle dysmorphia, where the individual is preoccupied with this perception that their muscles are too small, or they're not muscular enough. And let's see, wait, the specifiers use even the individuals. Yeah, exactly. Like if it's the focus is on muscle presentation and essentially bulk, this is where people, by the way, get some sort of plastic surgery to be able to fix this. I think the reality is it doesn't actually fully fix the issue. Yeah, because cosmetic surgery is common, but I don't think that it's actually very effective in reducing it, because it's still this almost delusional perspective of what's happening in the body that others can't see. Because of this preoccupation, looking at criterion B, at some point during the course of the disorder, the individual has performed repetitive behaviors. Okay, so preoccupation, and then so that's the obsessions, and then we engage in the compulsions. These are the repetitive behaviors: mirror checking, excessive grooming, skin picking, reassurance seeking, overly styling, covering, highlighting, maneuvering, repetitive behavior to try and quell the fear about this preoccupation with some sort of defect. And mental acts like comparing their appearance with that of others in response to the concerns. I think the mental acts, that's a big one, is constantly comparing, constantly checking, just really engaging in, yeah, but I don't look like this. I need to look like this. And so we see this with people's concerns about their face, their nose, their ears, any body part. Body dysmorphic disorder does not discriminate. So what we want to rule out is criterion D, that it's not better explained with essentially concerns with body fat. That this is not better accounted for by an eating disorder. And that's what we'll talk about it again in the eating disorder section. But ultimately, it is this excessive time consuming process of getting my nose to look smaller, hiding my ears, wearing clothes that hide my calves because I think that they're too big. Booking consultations for different plastic surgeons to be able to fix this, manage that, whatever that is. Distressing, overwhelming, time consuming, right? Okay. We have specifiers that we can speak to as far as insight, again, that are the exact same as what we saw in OCD: good, fair, poor, or absent or delusional beliefs. And again, as we get into eating disorders, we'll see that preoccupation of thinness in anorexia can be very delusional, that there's never enough weight to lose, and that even when a person is skeletal, they still perceive that they have more weight to lose. Whew, it's really very tough. Okay, other obsessive compulsive disorders, we're almost at the end. Hoarding disorder. So this is persistent difficulty. I don't actually have the snapshots of the disorders here. Why do I have an explanation again of body dysmorphic disorder? I don't know. I think I made this slide long ago, and then I added the other one. That's right. So hoarding disorder, this is just where I want you to have like an overarching understanding of this. This is persistent difficulty discarding or parting with possessions. And that thought of doing so essentially causes significant distress, to the point that a person will accumulate so much stuff because they have this fear of letting go. They have this fear that the obsession is that I'm going to need this later. And the compulsion is I have to continuously hold on to it. I have to collect more because I don't want to run out. Because what if I'm going to need this? What if I've worked with people. I do a lecture every year in La Mesa for one of the community centers talking about clutter. And it's really like low key an education on hoarding disorders. But the stuff that I've heard from people where it's like they've had loss and they don't know how to grieve the loss. And so they hold on to everything that their loved one has had, including like a styrofoam cup from a restaurant that they went to that somebody can't throw out, difficulty discarding possessions because of this fear of I'm going to miss them, I'm going to need this. What if I have nothing? And what that looks like is continuously collecting stuff. On the slide, you'll see an anecdote of, and this is like a very modified version of a client that I had that I worked with for a long time about their hoarding behaviors that ended up being very costly and very distressing to get rid of. That's a whole other story. So that's hoarding disorder. I'm repeating a body dysmorphic disorder. The repetitive behaviors, this is where what I also can say, like pinching body, checking mirror. I said skin picking, excessive grooming. Yeah, okay. The last two are trichotillomania. So this is recurrent pulling of one's hair, which results in hair loss despite repeated attempts to stop that hair pulling. And the result is significant distress or impairment. That's where we see in these two disorders, we see this experience of, oh, shoot, I'm sorry, I'll get there. And then excoriation is recurrent picking of one's skin, which can result in lesions despite their attempts to stop picking the skin, and which causes a significant amount of distress. And so the difference between excoriation and skin and excoriation and skin picking in that disorder versus picking at the body in body dysmorphic disorder is that one comes from this tension that I'm going to talk about in the cycle, comes from this tension and needing to deal with that tension, manage that tension with the skin picking versus tending to the defect in the body, which is that of body dysmorphic disorder. And so excoriation does not come from a distorted belief about one's appearance. This comes from the tension around that feeling of picking the skin. So ultimately, these disorders are really interesting. I think that they're quite rare. I think I've only worked with like one or two people that have trichotillomania. I've never worked with somebody that has excoriation disorder. But ultimately, what we see is that there's some sort of antecedent, fear, anxiety, boredom, intrusive thoughts that can happen. Again, this is why we have this filed under obsessive compulsive disorders. And then there's tension. And the tension essentially gets localized either in the hair or on the skin. And so a person is sitting with, I've got to pick this, I've got to pull this, I have to do it. And they engage in that behavior, that picking, that pulling. And usually there's this immediate relief. And there's this obsession about pulling out hair the right way, obsession about, or like a compulsion with pulling hair out the right way, of being able to get the whole follicle and then like touching the actual follicle that's connected to the hair. That's like very, very satisfying. So after that immediate relief, unfortunately, comes that consequence, which is a loss of control, embarrassment, or shame. And the person that I worked with when I was unlicensed would not even talk to me about this. She was like 17. At first, she would not talk to me about it at all. Her mom brought it up. It's very embarrassing for her. Just the back of her hair where it was covered was just had this like big bald patch from all of the hair pulling that she had done. And so we had to work through what the cycle looked like. But she did not want to talk about it at all. It was really tough to be able to engage in this process. And so ultimately what somebody experiences is a loss of control, shame, or embarrassment of like, I can't handle this. This will serve as a template to better understanding eating disorders when we get there too. But I want you to know like essentially what that can look like. That it starts with a feeling, it creates tension, that a person has a fixation. So the feeling is almost like the obsession. The tension is the anxiety. The behavior is the compulsion. Then there's immediate relief. What we can see in OCD that isn't listed is the loss of control, embarrassment, or shame, depending on the person's insight. But what we really do see in these disorders per the DSM for trichotillomania and excoriation is that experience of shame, guilt, loss of control, etc. But then not being able to know how to manage the feelings that come up intrusively, the thoughts that come up intrusively as a result of that. Okay, we've gone through all the disorders. So I have a list of the treatment of anxiety disorders here, evidence-based theories. I'm not going to go through them. Oh my goodness. I'm not going to go through them, but you can look. We have lots of different medications that really are effective in handling this, and this is what we are trying to recognize as when anxiety medications are needed, what anxiety medications are really needed. Benzodiazepines, so Xanax, Valium, Ativan, Klonopin, those are not effective for the overall treatment, or those are not indicated for the overall treatment of like generalized anxiety disorder. This is really better for panic. There is a tolerance that gets built up very quickly. Coming off of these medications is not easy, ideal, etc. And so our practitioners now, fortunately, are quite selective with how they put people on benzodiazepines. There are just other medications that are a lot easier to go off of: SSRIs, SRNIs, neuropinephrine. Is that right? Norepinephrine. That's what I meant. That the tolerance factor really isn't there in the same way. And therefore, the withdrawal factor really isn't there in the same way either. So what I do not recommend is cannabis for the treatment of anxiety and panic. It does not go very well. So we have short-term and long-term goals. You can refer to these for your I Can Start assignment. And then I think I have more immediate goals, smart interventions, short-term goals. There's lots of stuff that you can utilize here if you'd like for your I Can Start 3. And then here's more information about treatment of obsessive-compulsive disorder using the Yale-Brown Obsessive-Compulsive Scale and different interventions that can be used for OCD. This is a lot of stuff. So I just wanted to give you some resources on these slides. And then in these last slides, this is where there's a breakdown in the anxiety disorders, of separation anxiety, of all the disorders as far as the age of onset. Again, we know that there's no age of onset specifically, but when this can show up, the overview of the disorder, particular rule outs. So this comes obviously from the DSM. So just very comprehensive overview of all of the disorders that we talked about. Hopefully that's helpful for studying. And here is your case study for Joseph. It says chapter 5, but it's really I Can Start 3. That's going to be in the module for you. And so you will do a full I Can Start 3 for Joseph and identify what he is experiencing in this particular phase of his life. And we'll talk about it in week 10. But so for next class, that is due week 10, you're going to complete your I Can Start for Joseph. We'll talk about trauma and dissociative disorders in week 10. And that's it for this lecture. Thanks, everybody. Bye-bye.